Hello and welcome to another live broadcast with MedStar Health. My name is Sarah Ridenauer. November is Lung Cancer Awareness Month, and to kick us off, we're discussing who is at risk for lung cancer screenings, treatment options to consider if lung cancer is detected, and more with our lung cancer specialist from the MedStar Georgetown Cancer Institute. Today we have Dr. Edward Chan, a thoracic surgeon at MedStar Georgetown University Hospital and MedStar Washington Hospital Center, Dr. Jessica Wang Memoli, an interventional pulmonologist at MedStar Washington Hospital Center, Dr. Ankit Madan, a medical oncologist at MedStar Southern Maryland Hospital Center, Dr. Katherine Chen, a radiation oncologist at MedStar Franklin Square Medical Center and MedStar Health Bel Air Medical Campus, and our nurse practitioner for the lung cancer screening and nodule clinic at MedStar Washington Hospital Center, Namita Puran. If you'd like to know more about lung cancer and when it's important to seek a consult, then stick around, share this broadcast with your friends, and please ask your questions for our experts in the comments below. So welcome, experts. Thank you again for joining us. We really appreciate you all being here today. Before we begin our discussion, I'd like to go around and learn a little bit more about each of you and the work you do for MedStar. So we'll start with you, Dr. Chan.
Sure. Thank you so much for having us today. My name is Edward Chan. I'm the Chief of Thoracic Surgery here at Washington Hospital Center. I practice at Georgetown Hospital as well. And so I'm a thoracic surgeon specializing in surgery for the lung and the esophagus.
Great, thank you. Dr. Wang Memoli.
Good afternoon. Thanks for having me. I am at MedStar Washington Hospital Center. I've been here for, I'm not going to say how long because it makes me feel old. I am the director of interventional pulmonary and bronchoscopy, and I mostly do lung cancer diagnosis and staging and kind of set them on their way to see someone like Dr. Chan or Dr. Madan or Dr. Chen. So I sort of am in between Namita, the screening part, and getting to the treatment part.
Great, thank you. Dr. Madan.
Yes, thanks for having me. So my name is Ankit Madan. I'm a medical oncologist and hematologist at MedStar Southern Maryland Hospital Center in Clinton. I treat patients with lung cancer as well as with blood malignancies and other solid tumors. And I've been at MedStar since August 2022.
Awesome, thank you. Dr. Chen.
Hi, I'm Katherine Chen. I'm a radiation oncologist, primarily based out of Franklin Square and Bel Air. I do treat all cancers, head to toe, but lung cancers are a really important part of my practice with how common they are, how serious they are. So very happy to be here.
Great, thank you. And Namita.
Hi, happy Monday, everyone. I'm Namita. I work with Dr. Wang Memoli at Washington Hospital Center. I primarily do lung cancer screening, so that means talking to our patients about what to expect when you do a lung cancer screening exam, what kind of follow-up is needed, and then if we find anything concerning, kind of like being the navigator to help coordinate with all our specialists that are here today. So thank you for inviting me.
Yeah, of course. Thank you for being here. Let's get into our questions. We'll start with risk factors. So, Dr. Wang Memoli, can lung cancer be prevented?
I wish I could say there was something magic you could take or do and say, you're never going to get lung cancer, but it's not, we don't live in that kind of a world. So you can't really prevent lung cancer, but there's a lot of things that you can do to minimize your risk. The biggest one really is smoking. Don't smoke, and not just cigarettes, really don't smoke anything, because anything that you inhale can increase the risk of causing changes in the lung and lead to injury, including things that you inhale on the job, or any other recreational activities that you might do. So really, that's probably the biggest thing to do that can sort of decrease your risk of getting lung cancer.
Mm-hmm. And so who is at risk the most for lung cancer?
So I think, as most people know, the people who are at biggest risk are smokers. Really, people who have smoked for a certain amount of time. So if you smoked a cigarette here and there in your teenage years, probably not as big of a deal. It's the more routine smokers, so people who smoked, on a daily basis, for 10, 15, 20 years, those are the people that we start being more concerned about. And then the other people who are at risk are anybody who's had other cancers. So if you've had cancer elsewhere in your body, we know your body can make cancer. So those are the people that we have a little bit more concern about lung cancer in, especially if they're smokers. And then the one other population are people with occupational exposures or who have had first-degree relatives with lung cancer. Those are sort of the biggest risk populations that we're looking at.
That's good to know. And another important thing is, what are some of the warning signs or symptoms of lung cancer people should look out for?
That's kind of the toughest question because most people with lung cancer feel nothing. Lung cancer starts off pretty small. Your lungs themselves don't have any pain sensors. So most people who have something growing in their lungs don't feel it, which is why lung cancer screening is so important. But sometimes people will have some symptoms, things like weight loss, loss of appetite. Sometimes people will have a persistent cough that doesn't go away. Sometimes if they have a cough with sputum that tastes kind of weird or different than their normal sputum if they have a cough. Sometimes people have chest pain, shortness of breath. Those are probably the big ones that will sort of clue you into maybe something's going on in your lungs. Unfortunately, the problem is a lot of times by the time people feel something, the cancer is usually fairly advanced in the lungs.
And I know you went over the who's at risk for lung cancer. So how do you determine if someone is at high risk for developing lung cancer?
Those are really the important criteria for lung cancer screening. Those are the people who we're concerned about the most. So people between the ages of 50 and 80 who have had a greater than 20-pack year history of smoking. And what that means is someone who smoked, for instance, a pack a day for 20 years, or a half a pack per day for 40 years, or 2 packs a day for 10 years, sort of comes out to what we call 20-pack years. If you've quit, that's great that you've quit, but that doesn't sort of get rid of your risk for lung cancer. So if you've quit, it's for people who've quit within the last 10 to 15 years. Those are the people that we have the biggest concern for. And those are the people who we should really be pushing for screening. Now, the other at-risk populations, people who have had other cancers or people who have first-degree relatives with lung cancer, we still worry about them. We just don't really have the knowledge yet to know whether screening works for that patient population yet.
Okay. And going along with that, you mentioned screening. If someone is at high risk for lung cancer, what should I do? I'm guessing go get a screening.
Yes, absolutely. And it's such an easy thing to get done. It's a 10-minute scan. You're in and out in 10 minutes. You do it once a year. So ask your doctor about it. Ask your primary care doctor. Say, you know what? There's something called lung cancer screening. Do I qualify? Do I meet these criteria? And go out and get it done. It's very minimal radiation risk. I mean, it's so worth it because, as I said, most people don't feel when they have lung cancer. And if we find lung cancer at the stage where you don't feel it and we can cure you, you have a much better chance of long-term good outcomes.
Good to know. And going into screening a little bit more, Namita, what should a person do if they fit the criteria or at risk for lung cancer? Go get the screening, but I guess where do they start in that process?
Yeah, that's a good question, Sarah. So most of the times, you talk to your doctor and they inform you, hey, lung screening might be good for you. You're in the right age group, you have a smoking history. But sometimes, you hear about it like on TV, there's like a whole ad campaign for lung screening, and a lot of places allow you to self-refer. That means you call up the site and say, hey, I want to do lung screening. Washington Hospital Center is one of those places. If you would just speak to your doctor, that would be a good starting place. Like, hey, I want to know like what my lungs are up to. You could check in with them and see if you qualify. But just as Dr. Wang Memoli mentioned, if you're in the 50 to 80 age range, if you have a history of smoking, currently smoking, or have quit within the last 15 years, you qualify to get your lungs scanned. Now there is like some things that say if you currently have symptoms that are more concerning for lung cancer, such as losing weight without trying, maybe coughing up blood, maybe some other concerns like a cough that just won't go away, potentially your doctor might not recommend screening and would recommend something called a diagnostic CT scan. So it's important to talk to your doctor to kind of get, a good idea of what you actually should be getting.
Yeah. And then how is the lung cancer actually detected?
Yeah, so primarily it has to do with a CT scan, whether it's a screening exam similar to what our team does, or a diagnostic CT scan. We look in your lungs with a CT machine. A CT scan is, like Dr. Wang said, very quick. It's about 10 minutes start to finish. You don't have to take off your clothes for this exam. For our screening exam, you don't have to have any injections done. So I know a lot of people are afraid of needles. Not a concern. With this scan, we get plenty of details, all the details we need for lung screening and diagnostic CT scans without any kind of contrast. And then the radiologist will read that exam and will assess whether or not there's anything concerning, any spots on the lungs that could be concerning for lung cancer. I will say most spots are considered negative or benign for lung cancer, but some things are larger or have unusual shapes that are more concerning for lung cancer. And at that time, the radiologist would inform your doctor if there was a concerning finding, and then the doctor or whoever ordered that exam, the provider, would contact you and go over those results and tell you what the next best steps are.
Okay. Thanks for going over that. And you touched on this a little bit, but what are the screening guidelines?
Yes.
And what happens if someone doesn't meet screening criteria, but they're still concerned? What should they do?
Yeah, and so they are actually a very strict set of guidelines because of, this is covered as a cancer screening exam under the Affordable Care Act. So what that means is for somebody who is the ages 50 to 80 or 50 to 77, if they have Medicaid, Medicare, they qualify for lung screening if they have a 20-pack year history of smoking or greater. So 20-pack year history would typically mean, like Dr. Wang went over, say, for example, you smoked half a pack a day for 40 years, or maybe a pack a day for at least 20 years. And you had to have be either a current smoker or quit smoking in the last 15 years. Beyond that, they say that based on the current research, there's no benefit for screening, although, that might change in the future. And then, so if you do qualify, obviously talk to your doctor. You would be able to get an order to get the scan done. You do need an order from some provider, whether it's a physician or an NP, to get the scan done. Now, for example, if you don't qualify, maybe you're younger than 50, maybe you're older than 80, maybe your pack year history based on those very strict criteria are not high enough, I would recommend you talk to your doctor. Talk to them about what other potential ways you can mitigate your risk. Potentially you might be currently smoking. It's considered to be the first best step for your lung health to quit smoking. And perhaps you have other symptoms. Maybe that shortness of breath we talked about, maybe that severe kind of cough that just won't go away. And you may qualify to do another kind of scan, a diagnostic scan, to kind of assess, why do I have those symptoms? And outside of this, I would say talking to your physician if you have any concerns, like know your body best. So if something just doesn't feel right, talking to your provider and saying, hey, I'm concerned. What are my next steps here? What can you do to kind of help me through this? I would say is my recommendation.
Yeah. Talking with your doctor is never a bad thing. It's always a good thing to talk to your doctor.
Absolutely.
Even if it's something little, it could be, it's always good to talk to them and double check. And now what is a low dose computed tomography?
Yeah, so that's a good question. A lot of people have heard CT scans, but not necessarily of low dose CT. So low dose CT is considered less exposure to any kind of harmful radiation. It's considered to be 1/5 the dose of radiation than a regular CT scan. So, that's kind of important because if you qualify for lung screening from 50 to 80, potentially you'll have a number of years of lung scans. So we want to make it as safe as possible, not exposing anyone to any kind of, excess radiation that could be harmful. And this is where a low dose CT scan comes in pretty important. It's, if I had to give you some numbers, it's considered to be, they call it millisieverts of radiation. So 1.4 millisieverts is in a low dose CT scan, but average background radiation, somebody just walking around downtown DC or just any local area, local city, is 3 to 5 millisieverts. So low dose CT is considered to be pretty darn safe.
Yeah, it sounds like it.
Yeah.
And now, how often should someone be screened? Is that something that maybe differs based on your risk factor? Can you talk about that?
Yeah, so most people, when they do lung cancer screening, will be told to come back yearly because we either found no nodule whatsoever or benign nodules that have less than 1% chance of becoming cancerous. Some people will be told to come back in 6 months if we have a little bit more suspicion about those nodules. Some people will be told to come back every 3 months. Other people will be told that, we're a little bit more suspicious of the spots we saw, and we'd like you to have a full body or other diagnostic scans. So it pretty much depends on what we see when we do a low dose screening for the first time. But I will say the majority of people are told to come back annually. And it is the best recommendation because things can change over time. We want to be able to catch things early enough where, if it is considered cancerous, we have the most options available for treatment and potentially cure.
Yeah. Well, thank you for going over all things screening. We're going to switch to diagnosis now. So Dr. Wang, how is lung cancer diagnosed?
So Namita sort of pointed out, you get the scan and you have something abnormal on the scan. And a lot of people are like, oh my goodness, it's cancer, which it may be. And that's the reason why we get these scans. But that's not the only thing that can be on the scan. That's not the only thing that gives you some abnormalities on a CT scan. So in order for us to figure that out, we have to, like you said, make a diagnosis. And so there's a multitude of ways that we can do that. It can be with repeat imaging. So sometimes we just get a scan down the line, and if the a spot that we see kind of stays the same or goes away, we've seen spots go away, then we're like, wow, that's pretty good. Then we know that it probably wasn't cancer because cancers don't go away. But if it doesn't go away, or if we're more concerned, then as some of us have heard, tissue is the issue, meaning we need to get a sample of that spot. And so there's a few ways to do that. Sometimes that's with a procedure where we do a biopsy from the outside in. That's called a CT guided biopsy. Sometimes we do a biopsy from the inside where I take a camera and goes down into the in through the mouth, down into the lungs, and do a biopsy that way. Sometimes it's actual surgery. So sometimes we say, you know what, let's just cut this out. We'll send you to the surgeon. They'll do a resection. We'll know what it is. It has the potential to be curative at the same time. So the decision about what the next steps are sort of depends on the patient and the individual and what it is that they have on their scans. It's not a one size fits all kind of thing. Mm-hmm. And so really it's just based on who they are and what we see and what other information we have on the patient.
Yeah. And now, what are the stages of lung cancer?
Yeah, I did bring up stage, and it's complicated, and there are poor trainees who are doing lung training. It's always a little bit like, when it comes to how we stage lung cancers. But very basically, there's 4 stages to lung cancer, 1 through 4. 1 is sort of the most localized, hasn't spread anywhere stage. So usually that means you have a lung cancer spot in your lung that's less than about 3 centimeters, which is about 1.5 inches. So pretty tiny, surrounded by normal lungs and no evidence that it's really gone anywhere else. Stage 2 usually means that there might be a little bit of spread to some of the localized lymph nodes, which is a complex system of drainage in your body. Or maybe the spot that we're looking at is bigger than 3 centimeters. That can increase your stage also. Stage 3 means it's spread a little bit further than that and might have sort of left the local area and as in more central part of the lungs and some of those lymph nodes, or the the lesion itself is pretty big. We call it a mass, is pretty large. And then stage 4 is the most advanced, meaning it's spread beyond just one side of the lung that you see the primary cancer and has gone elsewhere, either to the other side of the lung, to other parts of the body. And that's what we call sort of metastatic lung cancer. So, so sort of goes from very localized to sort of widespread from stage 1 to 4.
Okay. And you mentioned earlier talking about symptoms. You said typically it's not until the later stages where you start to show those symptoms. Is that right?
Yeah, and it kind of makes sense because
Yeah.
again, your lungs have no pain sensor, so you're not feeling anything until it starts to go elsewhere or involve or gets bigger where it might cause pain or it disrupts some of the blood vessels and people will have might cough up blood, or it's gone elsewhere and causes pain elsewhere or loss of appetite, weight loss, things like that.
Mhm. So yeah, that's why it's good to get those screenings so that it can hopefully be
Absolutely.
caught early. Now, are there different types of lung cancers?
There are, and if you had asked me that question about 15, 20 years ago, I would have said, well, there are, but we really only care about whether or not it's what's called small cell lung cancer versus non-small cell lung cancer. And most of that is related to what we could offer in terms of treatment, which I think Dr. Madan probably will touch on, but a lot has changed in the last 10, 15 years. We see changes on a daily basis in terms of how we can treat. And a lot of how we treat depends on the type of lung cancer. So instead of just small cell lung cancer versus non-small cell lung cancer, that umbrella of non-small cell lung cancers now includes squamous cell carcinoma, adenocarcinoma, carcinoids, large cell. So there's so many different types of lung cancer. But even more than that, instead of just saying the name of, some random lung cancer, we've gotten even more specific, looking at different kinds of molecular changes within the cancer itself. And that's really, I think, where a lot of the long-term benefits of what we're doing in lung cancer is based on, because now we're using all of those molecular changes, those genetic changes, and we're targeting those. And that's where we see the most benefit in terms of treatment, which is amazing. And so it is important to not just say, okay, you have lung cancer, but we have to figure out what type of lung cancer, because that makes a huge difference in terms of what we do for people.
Yeah. So we're going to talk about treatment next, going into that. But before we get to that, I want to pause and thank our viewers for joining in and listening to this conversation. November is Lung Cancer Awareness Month, and to kick us off, we're discussing who is at risk for lung cancer screenings, treatment options to consider, and more with our lung cancer specialist from the MedStar Georgetown Cancer Institute. We've got lots more to talk about, so stick around to learn more, share this broadcast with your friends, and if you have any questions for our experts, you can leave those in the comments below. So, Dr. Chan, getting into treatment, how is lung cancer treated?
Yeah, thank you, Sarah. Really grateful to be here today. It really starts with actively listening to our patients and seeing what they're coming to us with. And we're able to approach our patients with a great multidisciplinary team that involves pulmonology, surgery, oncology, and radiation oncology. So it's a real team approach that we bring to each patient.
And is surgery a standard part of treatment, or I guess maybe it depends on where they're at? Can you talk about that?
Yeah, surgery is an important part of taking care of these patients. It's really the standard of care for our earliest stage patients who are strong enough to go through surgery. So we do a lot of work to make sure that we're evaluating patients and figuring out what the best treatment plan is for each individual patient. But surgery is really important to be able to remove the whole tumor, making sure that we get the whole thing out. And as Dr. Wang alluded to, getting the lymph nodes out too, to make sure that we know if it's spread beyond the primary tumor itself.
And are there minimally invasive surgical options for treatment?
Absolutely. Yeah. So the way that I do all my surgery and the way my partners do all of our surgery is robotically. So we don't do it the old-fashioned way where we make a huge cut on the side of the patient's chest and rip through all the muscles and break bones and stuff. We have a much more humane approach these days. So we're able to do minimally invasive robotic surgery through 4 or 5 cuts that are about half an inch each between the patient's ribs. And this allows us to do really complex surgery through this minimally invasive approach. We've done lots of research that have shown that there's a major difference in patients' recovery from getting minimally invasive, especially robotic surgery. Patients have less pain afterwards. There's less bleeding during the surgery. They get out of the hospital faster. They get back to work faster. So there's a huge difference in terms of how we can approach this surgery and how we can do it in a less invasive way.
Yeah, that's great to hear. That sounds a lot better than getting ripped open.
For sure. Yeah.
And so going along with that, you've talked about how recovery tends to be better. Are there side effects from surgical treatment, even though it is minimally invasive?
Yeah, and that's a really important question. There are still side effects potentially. Patients have pain. They can have surgical complications potentially. That's why we really do a lot of work before surgery to make sure that we're mitigating as many of these risk factors as possible.
Mhm.
So we're doing really thorough to check to see if patients are strong enough to go through surgery. We're going to check their heart beforehand. We'll check their lungs to make sure they can breathe well after the surgery and that they have plenty of lung left, even after we've taken out a small part of it. And we really have to be very careful to make sure that, we're offering the surgery to the right patients and that they're strong enough and that this is the safest option for them.
Yeah. And then Dr. Madan, as a medical oncologist, how do you treat lung cancer?
Yes, so lung cancer in my field is typically treated with chemotherapy. The backbone is chemotherapy, immunotherapy, and now we have these oral TKI agents that really target actionable mutations. So I tell my patients it's not enough for me to just know that you have lung cancer. As Dr. Memoli touched earlier, we have to know whether it's a small cell lung cancer or a non-small cell lung cancer. So small cell tend to be more aggressive than non-small cell, and we treat them mainly based on how spread it is. If it's a localized small cell cancer, then we use a combination of chemotherapy with radiation. And nowadays, immunotherapy is used for maintenance as well. If it's an extensive stage small cell, then we use primarily chemotherapy and immunotherapy combination. But for our non-small cell lung cancers, again, the backbone really is chemotherapy and immunotherapy. And treatment depends on what stage it is. So say if it's stage 1, you go for surgery. Stage 1B and 2A, certain cancers have high-risk features where I may offer 4 cycles of chemotherapy to reduce the risk of mortality by 5%. Then stage 2B, stage 3, after surgery, it's a category 1 recommendation to use 4 cycles of chemotherapy. But when it's stage 4, then again, chemotherapy in combination with immunotherapy forms our backbone of therapy.
Okay. And you mentioned immunotherapy. My next question was that I've heard it can be effective in treating some forms of lung cancer. Is that true? And how widely available is it?
Yes, so 20, 30 years ago, all we had was chemotherapy, which was offered to all patients. A decade ago, actually 11 years from today, in 2013, immunotherapy was first approved for melanoma. So what we learned over time, our scientists have discovered that our own immune system can very effectively attack or recognize foreign antigen cells and tumor cells. But tumor cells tend to express these proteins that kind of puts our immune system in a dormant stage. So what they discovered was they found 3 receptors, CTLA4, PD1, PDL1, that if they're uninhibited, your immune system can actually respond and treat the cancers. So it was deemed actually the breakthrough of the year in 2013 by journal Science. Initially, there was, we as a medical oncologist were wary of using this, mainly because we had to learn the side effects and how to manage them. In a decade, we've we've really done well and come leaps and bounds in managing immunotherapy to a point where, it was first approved in stage 4 disease, but it's been so effective. And at times in 5% cases has resulted in such miraculous responses where 5% of the patients have survived several years that we've never seen before. And we've learned to manage it. Its use has actually come from stage 4 to now even stage 2 and 3. We're using it sometimes before surgery, a lot of times after surgery, during maintenance therapy. And with immunotherapy, the interesting thing is, we try to get this marker called PD-L1 tested on all tissues before we use it. Sometimes that information is available, sometimes it's not. But immunotherapy with pembrolizumab, atezolizumab is now approved in combination with chemotherapy, resulting in survival advantage in patients with unknown or low PD-L1. And patients with high PD-L1 typically respond well. And it gives us the option if person has a high PD-L1 score, but their age may be such that we can't use chemotherapy, then in those patients, we can use immunotherapy alone and it's much better tolerated, doesn't have the side effects that you would associate with chemotherapy. And we've used it in patients in their 70s and 80s as well. So it's come a long way.
Yeah, that's great to hear. And are there any new treatments available or any, that you're most excited about?
Yes, so, as I said, we're now moving into this era of precision medicine and personalized medicine. So, in non-small cell lung cancers, you have certain lung cancers that are driven by certain genetic mutations. These mutations, such as ALK mutation, ALK rearrangement, EGFR mutation, ROS1 mutations, we have personalized therapy, oral agents that target these DNA changes. And these patients tend to have a much higher survival than an average lung cancer patient. So now we are actually utilizing the genetic sequencing to treat patients. These driver mutations are typically seen in middle-aged females who are typically non-smokers or light smokers. And then we are, as we discussed earlier, we're checking PD-L1 status, tumor mutational burden, all these biomarkers that are actually helping us predict who is going to respond to what kind of therapy. So we have now trials that are looking at certain mutations such as STK11 mutation, KEAP1 mutations. These patients tend to have resistance to immunotherapy. So how we're tackling that is using dual immunotherapy combinations with ipilimumab and nivolumab. And these dual combinations are breaking through that immunotherapy resistance. So that excites me the most, that you're treating each patient individually. You're learning about that cancer and using the therapy that will have the best result for that patient.
Yeah, that's great to hear. And you touched on this. My next question was, are there any clinical trials available? You just mentioned one. Is there any others you'd like to mention or talk about that one a little bit more?
Yes, so we have clinical trials within the MedStar system. The 4 sites that have them are Georgetown, Washington Hospital Center in DC. And then in Maryland, we have Good Samaritan and Franklin Square. We have phase 1 and 2 trials that use chemotherapy and immunotherapy. There are a couple of trials with EGFR mutation and ALK rearrangement with the medications that target these mutations, as well as antibody drug conjugate trials are available. So we have options for patients who've either want it in first-line setting or usually after been treated for a few lines of therapy and don't have any standard of care options.
Great, thank you. Now, Dr. Chen, what is the role of radiation oncology in treating lung cancer?
Yeah, thanks so much, Sarah. I mean, not to toot my own horn, but radiation does end up playing a pretty important role in a lot of different lung cancers. I think, like Dr. Chan was saying, we really take a team approach. So most of our new lung cancer patients are getting discussed in these multidisciplinary tumor boards. We're kind of seeing what treatment plan might be the best approach for each person. And I wish it were the case where every person getting diagnosed with a lung cancer had a really small, early stage lung cancer. They were really healthy, really fit. They could see Dr. Chen, have a small surgery, be done with it. But I think unfortunately the reality of it is that that is not the case for all our patients. It may be that they are older, they have other lung comorbidities, or they may certainly, in some cases, just be unwilling to undergo a surgery. And we do take that preference into account. So, in these cases, we can use radiation in some early lung cancers to cure them by itself. In more advanced lung cancer cases, we may be combining with radiation with chemotherapy, like with Dr. Madan, to achieve a cure. But yes, we play a part in many lung cancers.
Yeah. And are there different types of radiation therapy available for lung cancer patients? And if so, how is it determined which one fits the patient best?
Yeah, there are a number of different types of radiation that we can use for lung cancer. And I think, when it comes to the technical terms, it's like an alphabet soup. There's just so many people hear about. They will ask about SBRT, IMRT, EBRT. I think to boil it down, it really is about choosing the best tool for each lung cancer. We have all these tools in our toolbox. Which one is the best fit for that case? So, for example, for our earlier lung cancers, the patients that may not be going to surgery, we will use a kind of radiation technique called SBRT, where we are basically focusing in high doses of radiation to that small area of lung cancer to try and achieve a cure. Where I practice, the way that we can do that is with a machine called the cyber knife, which sounds a little scary, not actually a knife. When you get radiation, it's pretty much just like getting a scan, but it's a nice piece of technology we have. It can actually track a lot of lung cancers as patients are breathing. That lets us do that. For other cases, for example, when we're treating, let's say, bigger areas of cancer, combining with radiation, we will kind of use more standard photon radiation, where we're delivering treatment over longer periods of time just to be more gentle with it. And at places like Georgetown, we also have proton radiations, which are more kind of they can have a lot of advantages in specific cases, like when cancer comes back after initial treatment in some of our younger patients, or kind of extenuating circumstances.
Okay. And how long does a course of radiation therapy usually last? Or once again, does it depend on what stage the patient may be at?
Yeah, I think that pretty much is it. It does definitely depend on what stage a patient is at. I mean, day to day, when people are actually getting radiation, it's pretty quick. It is pretty much like coming in for an outpatient scan. I think for a lot of standard radiation, I usually quote the time door to door that patients will be here as maybe about 20 to 30 minutes. It's pretty fast. For the early stage cancers, the ones that we are curing with that kind of more focused, more high dose radiation by itself, those treatments we can complete in just, I would say, a handful of days of treatment, sometimes 3, sometimes 4, sometimes 5, but it's pretty quick. For the longer courses, patients with more advanced cancers, also getting chemo, typically those courses are about 6 to 7 weeks, and that is daily Monday through Friday, but each day is not an all-day thing.
Okay. And my next question is, I'm sure a big question a lot of patients have, are there side effects from treatment?
Yeah, there are. I think really, unfortunately, any cancer treatment does have side effects. I think when it comes to radiation, we try to be really thoughtful in the way that we design the treatment to minimize the side effects, but it will usually be related to the area that the cancer is in and how extensive it is. So I think, a general cancer treatment side effect is feeling a little more tired. That can really be with any kind of treatment. On the radiation side, let's say if there are tumors or there are lymph nodes involved with cancer near the esophagus, during that longer treatment course, patients are getting chemo, they're getting radiation. Patients can feel kind of that sore throat, reflux symptoms. I think changes in breathing are not actually as common during radiation treatments, although they can happen. I think it's something that we tend to monitor more in the long term, right? So making sure that people are getting back to their normal lives, they're not developing side effects even after treatment has finished.
Yeah. Yeah, thank you for going over that. Before I get to my next question, we have a question from one of our viewers. They say, I went to MedStar Urgent Care to treat a respiratory infection. While there, I had a chest x-ray to see if I had pneumonia. They're not a smoker, but the x-ray shows a lung nodule. Could it be lung cancer, and what should they do? Yes, Dr. Wong.
I'll take that because we get a lot of those, random images that come up with something, and we call them incidental findings, meaning they weren't looking for something specific and they saw a nodule. If it was found on a chest x-ray, probably the next best step would be to get a CT scan. And I would say go to your primary care doctor and say, they said they saw something on my chest x-ray. Do I need something more? And oftentimes a CT scan is a better next step, ultimately, because a chest x-ray is just a two-dimensional image. They sort of just kind of see shadows go through your chest. And so that spot could be something inside your lungs. It could also be on your chest wall. It could be on the skin. It could even be outside of your body. It's hard to know. And so the best way to really tell is to get a CT scan, which is a three-dimensional view. The way we see the pictures is almost like we're taking pictures like they're slicing you like a loaf of bread. So we can see both the 3D view and see, oh, is it in the lungs? Is it somewhere else? And so that's probably the next best step. Who knows what it is? We just have to do a little bit more evaluation.
Yeah. Got it. Thank you for answering that. So is there anything new on the horizon for lung cancer screenings or treatment options that excites you? Anybody can answer this.
I can talk about the treatment options. So I think as I touched upon earlier, we are now learning that the cancer, each cancer is different, behaves differently, may look the same under the microscope, but what really determines your prognosis is the genetic markers that we are able to find out on next generation sequencing. So typically, NCCN guidelines suggest us doing this testing earlier on. So we know if you have any driver mutations, that will give you an excellent prognostic advantage and be on a treatment that can be done at home with an oral pill. That is an option available. Unfortunately, these cancers are rare. Majority, 95% cases, we have to use chemotherapy and immune therapy. And with these ever expanding list of mutations, we are able to find out who is going to respond well and versus those who don't. And as well as we are now finding out that we're checking circulating tumor DNA to see how patients are responding in real time, even before we do their scans. They are not FDA approved yet, but should be within the next few years.
Oh, nice. Okay. And if this is a big question too, if someone is diagnosed with lung cancer, should they get a second opinion? And if so, how do you go about doing that?
I always say, get a second opinion. Sometimes that's just for peace of mind. Sometimes it's to get a different point of view. Sometimes it's because you find someone, a physician or a team that you connect better with. There's a lot of different reasons why people may want a second opinion, and there's no reason why you shouldn't get one. We don't take it personally as the physician. We want you to get the best care that you could possibly get. Obviously, we think we're, pretty good, but you need to do for you what works for you. And so I always, tell people, get one. There's absolutely nothing wrong with that. And if it makes you feel more comfortable with what's going to happen to you, absolutely do it.
Yeah. Yeah, that's great advice. And another question I want to ask all of you is, what message do you have for our viewers? What would you want them to take away after watching this broadcast? And also, why should they choose MedStar Health for lung cancer screening and treatment? I'll start with you, Dr. Long.
I think the big thing is get screened if you have risk factors. It does save lives. The other big takeaway is lung cancer screening is the #1 leading cause of cancer death. So it's important to be aware of. And if you're a smoker, don't feel bad. Don't feel like, oh my gosh, I did this to myself, because I think a lot of people do that. You know, decisions are made. You did what you did, but we can help you, and we can help find cancers early so that we can help you treat it and cure it. I mean, I'm egocentric, so I think hospital centers got a great program. We've been doing this for a long time. It's multidisciplinary, and I think that's the key. I think all of our centers across MedStar have multidisciplinary groups, meaning there's pulmonologists, there's surgeons, there's radiation, there's oncology, there's radiology, there's so many, there's nutrition, there's palliative care, there's so many groups that are involved for this. And so you can get it from all different perspectives. And I think that's important when it comes to cancer care, specifically lung cancer care.
Great, thank
I would,
you.
I would echo some of that. I think what Dr. Wang Memoli was saying was really important, in that our screening rates are really much lower than they should be, given how common lung cancer is. So if you look at the rates of screening for mammograms, colonoscopies, those are in the 70 to 80% range of people who are eligible to get them, who are actually getting screened. Lung cancer screening, unfortunately, is as low as 10 or 15%. And part of that is that there's, a stigma associated with having smoked for a long time, and maybe this was preventable or something like that. But I think it's really important for us to emphasize that nobody should be ashamed or embarrassed to get the care they deserve. And I think that this is a really important step for everyone's health, to get screened if you're eligible. And if you have questions, definitely go to your physicians, go to your providers to find out what the next steps are.
Yeah,
Yeah, I mean, I tell this to my patients, right? Like, what's in the past, if you were smoking since you were age 15, right? You can't go back and change that. What's done is done. But you do have a lot of things that you can control right now. You can control whether you are taking that first step to get a lung screening scan. You can make a plan to stop smoking if you're someone who is smoking, or at least cut down. And not just for yourself, but for your loved ones too. I think we've got a couple of big family holidays coming up. If your dad, your parents are big smokers, Thanksgiving, Christmas, think about talking to them about it. And really, the earlier that you're catching these cancers, the cures are just, the chance of success is much higher. The side effects are usually a lot less as well.
yeah. And Namita, I want to get to you next. But before you give your answer, we have a question from our viewer. Does MedStar Health offer smoking cessation programs?
Yeah,
Namita, do you want to touch on that?
yeah, we absolutely do. So, it's actually been shown that if you have support, whether it's a medical provider or even like a family member or the quit line, you are 50% more likely to quit and stay that way. So getting support as you're working through the quit process is really important. And MedStar Health does offer a variety of ways to help you quit. We have smoking cessation virtual classes. And then I believe we're going to put the link in that for those classes. We also would encourage you to talk to your provider. Providers are trained to offer medication. When you do lung screening, you will typically be offered cessation options as well, medications included. And typically, when you are offered these options, we will be told about the tobacco quit line. In DC, the tobacco quit line is great because it offers you free medications, and I believe that's similar to DC and Virginia as well. So you get free medications mailed to your house, and you get that kind of intensive counseling that has been shown to help you quit and stay that way. Because we know that people who do attempt to quit smoking may have attempted this multiple times. And it is a process to quit. A lot of times people say, well, I've been like Dr. Chen had mentioned, I've been smoking since 15. What a lot of people don't know is that when they may have started smoking cigarettes, they were not half as addictive as they are now. It doesn't make it impossible to quit though, because there are a lot of different ways to help you, talk therapy, medications, and we'll provide that typically when we talk to you about ways to quit smoking, tips, and other ways that you can improve your lung health when you do talk to your providers about smoking cessation.
Great. Thank you for going over that. And thank you, Emma, for your question. That fit in perfectly with our little wrap up. Dr. Madan, did you have any last final thoughts for our viewers?
I think as everybody, all of my colleagues touched on, I always get asked this question, Dr. Madan, you're an oncologist. Tell me, how do you prevent cancers? You treat them, and we all know like an ounce of prevention is better than a pound of cure. I think it's important to speak to your provider, doctor, about getting help that you need to quit smoking. We know that combination therapy with nicotine replacement and behavioral therapy and follow-up increases your chances of quitting smoking. And then if you have smoked, you need to get your screenings done so you can be treated with definitive surgery and not having to get future treatments that we talked about. And we offer that at MedStar through a multidisciplinary approach like we have today.
Yes. Great. Well, those are all great points to wrap up with. So thank you to our experts once again for joining us, taking time out of your day to answer our questions, and to our viewers for tuning in. To learn more, you can visit medstarhealth.org/services/lung cancer, and we'll post that link in the comments. Thanks again for tuning in, and we'll see you next time.